Hi, I'm Dr. Jared Christensen from Duke University. I'm a cardiothoracic radiologist, and I'll be speaking today on cardiac MRI for coronary artery disease. By way of disclosure, I am a consultant for a company called Riverine Technologies, but it has no impact on this specific topic. So today we'll be going over the 17 segment model of myocardial description. We'll touch upon myocardial viability imaging, cardiac stress MRI. We'll then go through some cases and review some take-home points. So why is imaging for myocardial infarction important? Well, it has to do with patient outcomes and survival. From the time of an initial ischemic insult, within about 60 seconds, the myocardium begins demonstrating reduced contractility, becoming either hypokinetic or completely akinetic. That obviously impacts cardiac output. Within about 30 minutes, we start to lose myocardial viability. That's a function that we're no longer going to recover despite treatment. Along that spectrum, ischemia begins in the subendocardial layer. That's the layer closest to the chamber. So if we kind of mag this up, we can see that with the ischemic insult, the myocardium becomes has reduced perfusion, starting at the subendocardial layer and working its way back to the mesocardium and eventually reaching the subepicardium. Now, this loss of function and viability, eventually, if not restored, will result in tissue necrosis, and that happens anywhere from 2 to 4 hours following the initial ischemic insult. So the timely diagnosis of ischemia is very important. By the time we reach 6 hours, typically you're looking at a transmural infarct and significant functional impairment that is not going to be recoverable with intervention. So when we're describing abnormalities on cardiac MRI, we want to use a uniform convention, and that which has been widely adopted and accepted is the 17 segment model. And so we're going to review this segmental anatomy. So in this particular static delayed enhanced image, we have a subendocardial focus of delayed enhancement or hyperenhancement. And how would we accurately describe this if we're reporting or communicating with our cardiology colleagues? Well, we're going to review this. So there are important anatomic descriptors that we use to describe where pathology is located, the extent, etc. The first thing we'll talk about is the myocardial distribution. So is the abnormality located at the base or basal layer, mid, apical, or apex? And we'll see how these are distributed. So on this 4-chamber view, we have kind of the most basal aspect at the level of the valve plane and then all the way at the apex. The basal component is if we were to take a slice just beyond the mitral valve there, and we can see the 2-chamber short axis view, what it looks like. There's really no papillary muscles. It's fairly smooth. We're getting portions of the right ventricular outflow tract before it goes to the pulmonary artery. And this is what the basal segment looks like. As we move a little bit further down, we start to see on the short axis view papillary muscles, and this constitutes the mid segment of the left ventricular myocardium. As we move a little more further toward the apex, in the apical segment, the papillary muscles start to kind of spread out. They become more interdigitated with the myocardial wall. And then our final segment is at the myocardial left ventricular apex. As we see here, it's small, the myocardium and the trabeculations are fairly well defined. In addition to the basal, mid, apical, and apex distribution, we can further subdivide this into myocardial segments. We're going to review these here. So this is what's known as the 17-segment model, and it takes the basal, mid, apical, and apex, and it further subdivides it into various categories, anterior, inferior, lateral, and septal. And so let's take a look at these. So the most basal segment, that is the outer ring, takes a look at our anterior, anteroseptal, infroseptal, inferior, infralateral, and anterolateral segments. And so we can describe something if we say it's segment 2, or we can say it's basal anteroseptal. They mean the same thing. The next ring of this model represents the mid portion of the myocardium with its corresponding segments. The next innermost ring is the apical portion, constituting segments 13, 14, 15, and 16, with the true apex representing segment 17. And so again, using this convention, we can identify precisely where pathology is located. And those reading our report or with whom we're conversing will understand exactly the location of the pathology. Now, these segments correspond to coronary artery territorial distributions. Classically, the LAD distribution is primarily anterior and anteroseptal, extending all the way to the true apex. The RCA is more inferior and infroseptal, and then the circumflex artery territory is essentially the lateral wall. Now, it's important to recognize that there can be quite a lot of variability in the coronary artery distribution. For example, if you have a left dominant system, then the LAD takes over more of the apical segments, and the left circumflex artery also takes over more of the inferior wall segments. But really, it's a lot of variability depending on if you're right, left, or codominant, the degree of collateral vessels, as well as just individual anatomic variation. But it's important to keep that in mind. In addition, when we localize abnormalities, we refer to the myocardial layers. So looking at, again, the short axis view, we can have a subendocardial distribution, which is the classic distribution for an ischemic process, starts in the subendocardium. You can also have what's referred to as a mesocardial, so it's only involving the midwall. Again, we see that in non-ischemic cardiomyopathies. A subepicardial distribution, again, most common with specific non-ischemic cardiomyopathies, and then also transmural. And so, again, this is a pattern often associated with ischemic disease. However, there are non-ischemic processes that can also have a transmural appearance. So getting back to this initial image that we showed with this subendocardial defect, we now know that we can see that there are portions of papillary muscles here. So we're looking at the mid portion of the left ventricle. It's involving the anteroseptal segment, which corresponds to an LAD territory. And it's greater than 50%, which makes it transmural. And we'll talk more about transmural extent later in this lecture. All right, let's talk about myocardial viability. So this is really kind of the bread and butter imaging that we perform in cardiac MRI. And the scan itself is fairly basic, and it can be performed in anywhere from 15 to 20 minutes, depending on the number of sequences that are performed. And these typically consist of localizers, steady-state free precession imaging performed in axial, 4-chamber, 3-chamber, and short-axis views. First-pass perfusion, this is an optional sequence. You can just give contrast, wait, and then go on to your delayed enhanced imaging. But we like to perform first-pass perfusion as part of our viability scan. This can help identify peri-infarct ischemia in the setting of acute infarction. And then finally finishing up the scan with delayed enhanced imaging after gadolinium administration. Delayed enhanced imaging is really the key sequence when it comes to coronary artery or identifying infarction on cardiac MR. And what this is it's hyperenhancement. So in normal myocardium, the myocytes are fairly densely packed together. And so when you give contrast, there's a relatively low volume of distribution within the actual myocardium. It rapidly washes in, rapidly washes out. And as a result, by the time we perform delayed enhanced imaging, normal myocardium is essentially low signal. There's really no enhancement. Hyperenhancement occurs when we have an absence of viable myocytes. And so you have myocytes that are damaged or injured in some way. The abnormal tissue allows gadolinium to actually leak out into the extracellular space. And as a result, we get an increased volume and distribution of gadolinium in that area. And this results in a slower wash-in of gadolinium as well as a slower wash-out. And so gadolinium gets trapped, and you accumulate gadolinium in the area of myocyte damage, resulting in an increased T1 shortening at imaging, which manifests itself as hyperenhancement on the delayed enhanced sequence. Now, it's important to remember that we can differentiate between acute and chronic MI, and there is some overlap in the imaging features. And so, for example, this is a steady state free precession, and as we look at it, some portions of the left ventricular myocardium are contracting, but if you look at the septum in particular is not really contracting. There's no variability in its thickness during the cardiac cycle. Now, motion abnormality is a sign that is present in acute MI, but it can also be present in chronic MI as well as in non-ischemic cardiomyopathies. And so it's not specific for coronary artery disease or infarct, but it is a sign that we look for and is often present in the setting of coronary artery disease at the time of cardiac MR imaging. A motion abnormality is often present, but it does not necessarily mean that there's an infarct. So you can have what's referred to as hibernating or stunned myocardium. This is simply myocardium that is actually viable, but is non-functional at the moment. Excuse me. And so it's viable but dysfunctional, but doesn't necessarily imply infarction. In addition to motion abnormality, we look at wall thickness. And so with acute MI, the wall thickness is usually normal, whereas with chronic MI, the wall becomes thinned due to scarring. We also see in acute MI myocardial edema, and this is best appreciated on T2-weighted sequences, such as a short tau inversion recovery, which is a fat suppression technique sensitive to changes in myocardial water content. And so we can see edema secondary to acute myocardial injury. Again, it's not specific for MI. We get myocardial edema and other pathologies such as myocarditis, but it is a finding that is often present in the acute setting that we would look for. Here we have a patient, two different patients actually, with T2-weighted sequences where we can see evidence of edema in the setting of acute MI. So on the patient on the left, we have this lateral wall area of hyperenhancement, and on the patient on the right, we have an inferior and infralateral wall abnormality. Notice also within that, there's kind of a mid-wall area of low signal. This actually represents acute hemorrhage associated with acute MI. And so it's something else that we look for. And it's important because this also has some prognostic implications. In addition to myocardial edema, we already discussed a bit about delayed enhancement or late gadolinium enhancement. This is something that we look for and is diagnostic for myocardial infarction in the setting of other findings. And then also areas of no reflow. And let's talk about both of these. So in acute MI with delayed enhancement, again, we're looking for hyperenhancement in a subendocardial distribution that conforms to a coronary artery territory. So in this particular example, we have subendocardial delayed enhancement. There's some mid-wall involvement as well. And it corresponds, it's confined to the RCA territory. And this is compatible with the RCA infarct. Now contrast that with this example. So we have abnormal delayed enhancement, but the subendocardium is actually not involved. Here it's primarily a mesocardial pattern throughout the septum, as well as portions of the lateral and infralateral walls. So this is not an ischemic pattern of delayed enhancement. This was a case of myocarditis. The transmural extent of infarct is also important to characterize and report. It's a predictor of prognosis for the restoration of contractile function post-revascularization. So simply stated, as the transmural extent of infarct increases, the probability of recovery decreases. And in fact, in a seminal study performed by Ray Kim, one of our cardiology colleagues here at Duke, they showed that this phenomena that as the degree of infarct becomes or increases, then the contractile or left ventricular function is reduced. If the transmural extent is less than 50%, then there's actually a very good likelihood that the patient will benefit from revascularization. In fact, they showed that if the infarct is less than 50% of the wall thickness, then the majority of those patients will demonstrate recovery post-intervention. Once you start getting above 50%, the 50 to 75% range, the percentage of patients who actually derive benefit from intervention decreases. It drops to about 10%. Once you're above 75%, there's 0% benefit. That myocardium does not improve function. Now, there's a lot of factors that go into that beyond just the transmural extent, but this is certainly an important component of our evaluation on cardiac MR for viability purposes. The other phenomena is that of what's called no reflow. So no reflow is an area of microvascular obstruction. So you get obstruction of the end arteries and capillaries within the area of infarction. And it's a sign of acute myocardial infarct. And in fact, during the development of the infarct where microvascular obstruction forms, gadolinium does not even reach that portion. And so there's no enhancement of that myocardium, either on first pass perfusion or on delayed enhanced imaging. And the pattern is somewhat distinctive, and I'll show some examples. If no reflow or no reflow zone is present, it's an indicator of severe ischemic disease. And it usually implies that there's a transmural process, and it's a sign of poor prognosis. So again, this is something that we look for on our viability scans, and it's something we report on to alert the referring physician of this prognostic indicator. So what does it look like? Well, here are three different patients with areas of no reflow. This is delayed enhanced imaging, and on the first patient, we see what looks like a subendocardial area of low signal. And in fact, as we first look at this, you may think that the delayed enhancement is really in a non-ischemic pattern. It looks like it's just involving the mid-wall. At least in the anterior wall, we can see that there's subendocardial involvement throughout the lateral wall and getting into the inferior wall as well. But in this particular area, we have this band that looks like subendocardial low signal. This can be tricky because this could represent normal myocardium. It could represent thrombus that is adherent to an area of infarct. And so we need to look at other sequences, including a high TI sequence to exclude the presence of thrombus, as well as looking at our first pass perfusion images to confirm that this doesn't represent myocardium. But this is in fact an area of no reflow in the setting of acute MI. We have a similar phenomena here in the infralateral wall on this patient. And then on the final image, we see again a fairly distinct band within the mesocardial portion of the myocardium in this patient, demonstrating a large area of no reflow in the setting of acute MI. What about chronic myocardial infarction? Well, the primary imaging features there, in addition to delayed enhancement, are we see wall thinning, as demonstrated in this case. The inferior wall is almost completely just gone. It's a thin, fibrous band. It's not moving, so we have wall abnormality, motion abnormality as well. And the presence of a fibrous or a fibrofatty scar. These are signs of chronic MI. And we also look for complications associated with MI, including aneurysm formation, the presence of thrombus, among others. We're not going to focus on chronic MI, but it's important to be aware of the imaging features. All right, we're now going to transition to cardiac stress MRI. We talked about viability scan, and now let's talk about stress MR. So we're going to devote quite a bit of time because it's still not something that's routinely performed at most institutions, but it is an emerging an important sequence for patients being evaluated for coronary artery disease. So what are the indications for cardiac stress MRI? Well, there's consensus documents that have kind of laid this out, and the primary indications we'll review here. So in patients who have acute chest pain, who are at intermediate risk for coronary artery disease, that's a primary indication. Patients who have chronic chest pain, who have low to intermediate risk for CAD. Now that encompasses quite a large number of patients with chest pain, either acute or chronic. Kind of breaking it down more specifically, patients who have a resting ECG abnormality and an inability to exercise, so they can't undergo a conventional stress test. Maybe they've had indeterminate prior non-invasive imaging, so that would be another indication to perform a cardiac stress MR. And also in patients who have known coronary artery disease, but we would like additional information to determine who may benefit from intervention. So those are the primary indications, and it's important to arrive at a consensus within your institution about when this test will be performed. So this is a pharmacologic stress test, so it's not exercise induced, and there's a couple different approaches. So we can take a look at myocardial perfusion. And to do that, you can give vasodilators. So there's adenosine or regadenosin, and there's dipyramidol, excuse me. And at our institution, we use adenosine. We have used regadenosin in the past. The benefit of regadenosin is that it's a single injection, whereas adenosine is a continuous injection. But there is the possibility with regadenosin that you'll have to reverse it by administering aminophylline, whereas with adenosine, you can just shut it off if the patient is developing symptoms. And so we're going to be focusing on adenosine in today's talk. It's also notable that you can also perform this looking specifically for wall motion assessment. And to do that, you'll use dobutamine instead of adenosine. But again, we're going to focus on the adenosine today, and that's really the most widely used. So adenosine is a vasodilator. It's relatively safe. It has a low risk profile. The literature states that about 5% of patients will report some degree of symptoms during the test. Most of those symptoms are pretty mild. They may have shortness of breath or some mild chest discomfort. But a small percentage of patients will develop AV block, and some will also have nausea. And so it's important to consent patients for these symptoms, letting them know the risk prior to the exam. As I mentioned before, adenosine is very fast acting. So if the patient does experience symptoms, it can be quickly shut off, and the effects really are diminished or go away within about 30 seconds. Excuse me. So how are patients prepared for the test? Well, they need to be in PO for at least 8 hours prior to the exam. They should stop taking xanthine derivatives, so methylxanthine such as theophylline or aminophylline, and caffeine as well. No caffeine for 24 hours. These medications, as well as caffeine, they act as adenosine receptor antagonists. So the stress test may be falsely negative if these are on board, so we don't want that. No calcium channel blockers for 48 hours and no beta blockers for 72 hours. Now, there are some contraindications to performing an adenosine stress test. So patients who are suspected of having acute MI, we don't want to do this because by administering adenosine, it can actually exacerbate, excuse me, their ischemia, and patients may end up having a more severe infarct. Unstable angina or rest angina is also a contraindication. If they're having uncontrolled arrhythmias, COPD with active wheezing, low blood pressure, these are the parameters we use here. If they have heart block greater than type 2A, or as I mentioned, some ventricular atrial arrhythmias. So it's important to screen the patients properly. Now, there are advantages of CMR over SPECT. Several studies have taken a look at this. So one of the primary advantages is higher spatial resolution. over SPECT imaging. There's also, it's a more sensitive test, so higher sensitivity, meaning that it only takes about a 50% reduction in blood flow in order to have an abnormal stress test on MRI, whereas for SPECT, you have to have about an 85% reduction in blood flow. There's no ionizing radiation, it's a shorter exam time overall, and there's fewer artifacts. So what are the outcomes with respect to CMR versus other modalities? Well, sensitivity and specificity for the detection of coronary artery disease is actually fairly similar across SPECT and echo and CMR. But when we look at positive predictive value, cardiac MRI stress is actually better than both SPECT and echo. In fact, stress cardiac MR imaging was found to be the strongest independent predictor of significant coronary artery disease compared to other diagnostic tests. Ischemia on stress MR is also predictive of cardiac events over a 3-year period. So if you have a positive stress test, that tells you, it provides prognostic information for that patient. And in fact, patients with a positive CMR stress test are 12.5 times more likely to have a cardiac event than patients who have a negative study. So abnormalities observed during stress MR really serve as independent predictors of adverse cardiac events. It has a very high negative predictive value. So if it's a normal study, you can be fairly confident that the patient does not have any significant coronary artery disease. So how is the test performed? So taking a look at this here, we're going to plot out time from giving contrast administration to signal intensity. And to do that, we'll start first by, we apply a gradient recall to echo sequence with a saturation pre-pulse, which will provide T1 weighting. And this helps us identify maximal differentiation in gadolinium concentrations within the myocardium. And so first, we'll place this kind of dot here. This is in areas of normal myocardium. And what we see is there's fairly rapid uptake. It reaches a peak, and then there's kind of a gradual washout. If we place an area of interest in some ischemic myocardium, denoted by the yellow dots in the infralateral wall, then what we see is there's actually slower perfusion of gadolinium in the abnormal myocardium. There's lower peak intensity, and it also has slower washout. And so this differential is what we're relying upon when we perform stress MRI. The technique itself is fairly straightforward. So we perform routine scouts and steady-state free precession images. We then administer adenosine, and it's given via continuous perfusion with ECG and blood pressure monitoring. We then administer contrast, and we'll perform our stress imaging. So breaking that down a little bit further. So we have started our adenosine infusion. It's important to note that patients may become symptomatic. They may have chest pressure, become short of breath. What we're looking for is they're going to become tachycardic, and eventually that tachycardia is going to reach a peak and will stabilize. And that's when you'll want to start your test. And so we usually give the perfusion, wait at least 2 minutes before giving contrast. At that point, the patient usually has reached kind of their tachycardic steady state. We then give contrast, followed by a saline bolus or flush. The patient will then begin breath holding at the appearance of contrast within the right ventricle. And breath holds are important because it helps minimize respiratory motion artifacts during the study. Once contrast begins to wash out of the left ventricular myocardium, we stop the adenosine, and the remaining imaging is performed for another 5 to 10 seconds. It just is kind of repeating during that perfusion phase. And the entire stress sequence lasts about 40 to 50 seconds, so it's not very long at all. Once we've as we set up for our stress perfusion, the slices are determined off of a 4-chamber view. And so this is actually a step before we actually perform the stress. But you select these slices that are representative of the left ventricular myocardium. And these specific images will be imaged with every heartbeat. Now, with tachycardia, it's you may not have sufficient time to cover the entire short axis of the heart. So what you can do is you can drop a slice to shorten the scan. And if that's still not enough time, then you may have to image every other heartbeat. However, this halves the sampling frequency during first pass perfusion. So it's not ideal, but it can be performed and still provide important information. So let's go on. Following the stress portion of the study, we wait for the blood pool to clear of gadolinium, and then we perform rest imaging. So we essentially repeat those short axis slices just without the presence of adenosine. And then we end the study by performing our normal routine viability delayed enhanced sequences. And all told, it takes about 45 minutes to get the entire exam. So, as you're performing this study, you should be aware of when you should stop the study. So, this exam should be ended if the patient develops a persistent or symptomatic AV block or another arrhythmia, if their systolic blood pressure drops by more than 20 millimeters of mercury, if they become symptomatic in the setting of hypotension, or if they develop respiratory distress. All right, so how do we interpret the images now that we have them? Well, our approach to interpretation relies on taking a look at our cine imaging. Here we're looking for wall motion abnormalities. We look at our stress sequences to look for perfusion abnormalities. We look for the rest to see if there's matched or unmatched defects. If it's matched, it may represent artifact. And we look at our delayed enhanced imaging to look for the presence of myocardial infarct. So those are the main sequences that we're going to be assessing. But as far as our approach to interpretation, we actually don't typically do them in that order. The protocol that we tend to follow for interpretation is we actually start with the delayed enhanced images. If there's a delayed enhancement, we know that the patient has coronary artery disease because they've had a prior infarct. That doesn't mean that we stop there, but it already tells us that, yes, this patient has CAD. If it's negative and there's no abnormal delayed enhancement, we take a look at the stress sequences to determine if there's ischemia. And so we're looking for areas of low signal on the stress. If present, then we'll compare it to the rest sequences to see if there are matched defects, which would imply artifact rather than inducible ischemia. If they're unmatched, then that would indicate that the stress is positive and inducible ischemia is present. So that's basically the approach to interpretation. Okay. Let's now put these principles to work. So let's take a look at some cases. First case is a 61-year-old man with chronic chest pain and a new ECG abnormality. So at the top, we have our stress images, our rest images, as well as delayed enhanced images. And so we'll start by looking at the delayed enhanced sequences, and we don't see any evidence of delayed gadolinium enhancement, so there's no evidence of scar or infarct. So let's look at our stress. We're looking for, again, perfusion abnormalities, which we don't really see. And we're looking for something that persists throughout the cycle. We'll look at the rest images just to be sure, and again, we don't see any abnormality. So what is our interpretation here? This is a normal exam, so a negative stress test. This patient actually still went on to have cardiac cath, but that was also normal. Next, we have a 57-year-old woman with known left circumflex CAD who presents with acute chest pain and an indeterminate stress echo. So we'll start with our steady-state free precession images, and what we see is there's thinning and essentially akinesis of the infralateral wall. And that corresponds to our left circumflex territory. She had known disease of that vessel. So let's take a look at our delayed enhanced images. And what we see is, wow, there's actually pretty abnormal subendocardial delayed enhancement with thinning. of that infralateral wall, but we see that it actually extends more into the anterolateral wall and portions of the anterior wall. So it's a bit more pronounced on the delayed enhanced imaging. At any rate, now we need to look at our stress and our rest images. So taking a look at stress and rest, what we see is there is a perfusion abnormality. It corresponds to the same territory of the infarct, but it's actually more than that. It involves quite a bit of the inferior wall as well. As we look at the rest, we don't see that perfusion abnormality. So this is a stress-rest mismatch. And it's not just due to prior infarct. Because we have this area of the inferior wall, which is positive on the stress, but there's no infarct there, that indicates that this particular area is at-risk myocardium. This is inducible ischemia. And so although the patient does have evidence of prior left circumflex infarct, they have inducible ischemia of the right coronary artery territory, and they would then benefit from intervention to preserve that myocardium. We now have a 64-year-old male with history of LAD MI presenting with angina. So here's the stress images. And what we see on the stress as it goes is there's near circumferential perfusion abnormality. It's essentially extending from the base all the way to the apex along the septum and anterior wall predominantly. I don't have the rest images here, but the rest was normal. So the patient was read as positive, and they went off for revascularization. So they actually ended up having their circumflex and their LAD revascularized. And we see in this bottom image, post-revascularization, there's essentially resolution of the previously seen anterior and kind of lateral wall defects. And so the septal defects remain, so they didn't gain any benefit there along the septum, but the anterior and lateral walls have normalized. Next, we have a 49-year-old male, acute chest pain, ECG changes, indeterminate enzymes at indeterminate risk for CAD. Here we have steady state free precession, stress, rest, and delayed enhanced images. And what I want to show here is that on the SSFP, there's severe hypokinesis. In fact, some areas of akinesis of the anterior wall and anterior septum. On delayed enhanced images, there's looks like a subtle subendocardial abnormality along the anteroseptum. On stress, though, we have a pretty large defect in this area. It's larger than what looks like the area of infarct on delayed enhanced imaging. And on the rest, there's also a defect. It's just not quite as pronounced than on the stress. And so this can be a little tricky because it's like, is this a match defect, or is the fact that it's more pronounced on stress, does that take greater weight? So what do we do about this? Is this artifact, or is this inducible ischemia? So this is actually a case of a patient with a prior infarction, as we see on delayed enhanced imaging, with what's referred to as rest ischemia. So what is rest ischemia? So basically, both artifact and rest ischemia will result in match defects on stress and rest imaging. With rest ischemia, the size of the defect tends to be more transmural or greater than 50%, whereas with artifact, it's usually less than 50%. So that's one thing we can use to differentiate if we have match defects. The extent of the abnormality tends to be greater on stress than it is on the rest, as we see in this case, whereas with artifact, they should be equal. And in the setting of rest ischemia, there's often going to be an associated wall motion abnormality on the SSFP, whereas with artifact, you should not have a wall motion abnormality. So even though on this case we had what looked like match defects, the extent of the defect was greater on the stress imaging It was more than 50% of the wall thickness, and there was abnormal motion. So all of those factors point to this being a case of rest ischemia rather than artifact. Well, what about artifacts? Well, most artifacts on stress MR are due to cardiac motion, and they occur at the chamber wall myocardial interface. And they typically don't adhere to coronary artery territories. They can be transient and vary in signal intensity throughout the exam. And it's, again, usually not transmural. It's going to be less than 50% of the myocardial thickness. So we've got two cases here. Patient A with our SSFP, stress and rest, and then patient B with SSFP, stress and rest. And patient A, we see that there's some apparent perfusion abnormality here, particularly along the inferior wall, and it looks like it's somewhat matched on the rest images as well. But we don't see a wall motion abnormality on SSFP. With patient B, there's significant wall motion abnormality of that septum in particular. On the stress, we have a transmural perfusion defect with a matched transmural perfusion defect on the rest. So which is artifact and which is rest ischemia? Well, using the criteria that we previously reviewed, patient A, the top patient, is artifact. It's less than 50% in thickness. And there's no associated wall motion abnormality on SSFP, whereas the lower patient, significant wall motion abnormality with transmural matched stress and rest defects. In fact, they're pretty well matched. It's not always that the stress is going to be greater than the rest. Okay, well, in conclusion, so this has been, I know, kind of a whirlwind tour through coronary artery disease on cardiac MRI. But what are some take-home messages? Well, cardiac MRI is an effective diagnostic tool for patients who have known or suspected coronary artery disease. And this includes the ability to differentiate acute from chronic myocardial infarction, to perform myocardial viability assessment, provide prognostic information, and even help direct treatment, as well as for patients who as of yet do not have a diagnosis of coronary artery disease. We can use stress MRI to evaluate for the presence of inducible ischemia. And stress MR is a better study in many instances than some of the more conventional stress methods. The 17-segment model. So this is essential. You need to be familiar with this for communication and reporting. And once you know it, it's going to be very easy to describe and localize pathology and to effectively communicate with surgeons and cardiologists. Indications for stress MR. So the primary ones are chest pain in intermediate CAD risk patients, but there are some other categories where it may be indicated. And so again, my counsel would be to establish consensus criteria at your institution. And then finally, we reviewed a systematic algorithm for not only performing, but also the interpretation of cardiac stress MRI. And with that, I thank you for your time, and I'll welcome your questions.